There in the end. Welcome to Grand Rounds. My name is Tom Fardon and I'm the chair of Grand Rounds, and I'm in this slightly peculiar situation of having to introduce myself as the speaker. We've been doing Grand Rounds for 2013, so it's 7 years. And I've presented once at Grand Rounds, so people do occasionally nudge me and say, well, when are you going to talk at Grand Rounds? And I say, well, you hear enough from me anyway, but people seemingly are keen. So I've sort of been prevaricating for a while now and have a talk in my back pocket just in case someone doesn't turn up. But on this occasion, there was a gap in the rota, so I kind of came to a head and I thought, well, I best talk about something. So here I am. I am a consultant chest physician here in NHS Tayside, and I've been here for 17 years as man and boy trainee and then consultant. And I'm going to talk to you today not just about my cycling holiday, but some of it is going to be about my cycling holiday. But I'm going to talk about smoking cessation and why it's an important part of what we should be doing, not just in the respiratory department but everywhere. I'm going to talk about some evidence of why, to show you that we don't do it, we should do it, and how we might get better. So I've called this put nothing in your lungs except fresh air, and the caveat of possibly an inhaler or two, but only if you need them. This is a picture of Russell Duncan, who's one of the Associate Postgraduate Deans and ED consultant, at the top of a mountain during the Archie Mountain Challenge that we did in 2014, raising money for the paediatric operating theatres. And here he is taking in the fresh air at about 1,100 metres up, overlooking this beautiful loch. Which brings me to my first cycling slide, which is here I am cycling. This is around Furset in the Highlands in 2014, and you can just about see, hopefully just at the back of here, the Archie rabbit thing here, which we were using to cycle around. It's a typical cycling day in Scotland, no sun at all, miserable, horrible, and wearing a lot of kit. But on to the talk. What will I tell you about? I don't think I need to convince you that smoking is bad for you, but I'm going to do it anyway. I'm going to show you that tobacco advertising has never really gone away, despite us being all proud of the fact that we don't advertise cigarettes and smoking, but we clearly do. And I'm going to show you some of that evidence and why it's getting worse. I'm going to try and convince you that tobacco addiction is a disease, and that smoking is not necessarily a lifestyle choice, and that tobacco addiction is a real problem that we need to support our patients with rather than berating them. I'm going to show you that there's a very strong evidence base for treatments that no one uses, and I'm going to try to relate to, would that ever happen in anything else? If there was a treatment which was had such a strong evidence base as this in cardiovascular medicine or anything to pick your speciality, would you ignore it? I'll show you what we've been doing in the respiratory department to try to improve things, and then I'm going to try and convince you that you in your own practice can do the same. So that's basically the talk. We'll crack on. So this is a picture from a tweet by Professor John Hurst, who's a professor of respiratory medicine down in the Royal Free. His children had been asked to do a project at school about something in public health, so of course they chose smoking, and this is the poster that his 7-year-old kids came up with I suspect a little help from Professor Hurst, of why smoking is bad for you. So I do not need to labour the point that smoking is bad, and every cigarette contains a whole host of different poisonous things that we wouldn't even dream of shoving anywhere near ourselves if it wasn't in a cigarette. The British Medical Journal in 1950 published this paper, the doctor's smoking study, following up doctors who smoked because it was believed to be good for us, showing that there was clearly a link between smoking and carcinoma of the lung. There were, after this for about 4 years, there was just a raft of data that came out showing the link between smoking and carcinoma of the lung. And I just picked that because obviously lung cancer is a big part of what we do. This was a paper from 2004 where the same author, Richard Doll, did a 50-year follow-up study. So they followed up all these people for another 50 years. I think this is an interesting outcome, that the substantial progressive decrease in mortality rates amongst non-smokers, so we are doing something good, due to prevention and improved treatment of diseases, has been wholly outweighed among cigarette smokers by a progressive increase in the smoker versus non-smoker death rate ratio due to earlier and more intensive use of cigarettes. So I hopefully don't need to persuade you anymore that smoking is bad. Advertising. Do you remember this? Are you all long enough in the tooth to remember the Embassy World Snooker Championships? And there was the Embassy World Darts as well. My cousin, who's currently a medical student over in Glasgow, has told me that you can't call it a sport if you can do it with a fag in your mouth. So she believes that snooker, darts, and even golf aren't really sports because you can do it with a fag in your mouth. And she's 22, so she has she can't remember Embassy this. But cigarette advertising was pervasive and everywhere when I was a kid. So I'm talking about, I was born in 1976, so we're talking about 70s, 80s, and into towards the 90s. Everyone remember the John Player Special Lotus car? Jake, you were just, what's coming next? It's the John Player Special car. And if you don't know what John Player Special is, then you would know after you'd seen Ayrton Senna spin around in it. And then everyone knows this car, which is the McLaren, but it wasn't called the McLaren, it's the Marlboro McLaren. Everyone knew it as the Marlboro McLaren. And it won countless races in Formula One. And Formula One is sexy, and it's the elite of the world racing around Monaco, and it's embedded in it for decades was smoking. And of course now that's all gone away, hasn't it? But this is the McLaren Senna car that came out last year, and it's in Marlboro colours. And you might say, I'm just picking at things here, but this kind of advertising carries on. That you get rid of the name, but you carry on the colour schemes, and it's quite pervasive. That I look at that and go, oh yeah, it's the Marlboro McLaren from a long time ago. But we've spent a lot of money, a huge amount of money across the UK in public health trying to bring down smoking rates. So there's these horrible adverts of, look what you're smoking, you're getting lung cancer, trying to get people to smoke outside their cars and not inside their cars. And I just picked a couple of these things of trying to reduce smoking rates across, these are from NHS England, and the 7 steps outside your car process. Here's a few more. Smoking in pregnancy. There was a paper in the BMJ this week showing that maternal smoking increases risk of childhood fractures by quite a significant amount. It wears off by the time the kids are 15. But we're still publishing data on new ways in which smoking affects people. Yet we've known about it for 70 years. And some of them are quite. Some of these images are quite striking. If you go to Australia, or New Zealand, if you go into Europe, as if we can get into Europe, of course, cigarette packets have 70% of the cases a horrific picture of some mouth cancer or other. When we introduced the smoking ban to Scotland, funding for smoking cessation in the country, out of the whole country's budget, was £500,000. Last year, the budget for smoking cessation in Scotland was £50,000. It's fallen to 10%. Yet it still remains a problem. Yet we've managed to, that goes completely under the radar. Here's my second photo. Me sat at the top of the Calder Telegraph in the hotel a few years ago. What I'm talking about here is this stupid set of gears that I put on because I thought I was young and fit, and I suffered for it later. But it's beautiful up there if this is the skiing in the winter, cycling in the summer. Do you remember these adverts? These are, I'm pushing back the years here, of Superman and Nicotine. Nicotine was the bad guy. He had his cigarette hat on, and Superman would chase down Nicotine, and Nicotine can't escape because he's so breathless. And he's a wreck. If he had X-ray vision, he could see he's already getting damage. And even in the Superman movie, there's a point where he does X-ray vision to see if the guy's got lung cancer or not. So you think Superman's the hero, but actually, more pervasive advertising. This is Superman 2 in 1980. Lois Lane smokes for absolutely no reason whatsoever. And it's just in a couple of scenes, and then it goes away again. But she smokes in there. And Philip Morris, the company that make Marlboro, paid $43,000, which in today's money is about £250,000, to have Superman fight against General Zod in the last fight and go through a Marlboro cigarette truck. There are 320 separate references to smoking in Superman 2. That's good return for $43,000. Doesn't stop there. One of my favourite films of all time, Ghostbusters. They all smoke. They're all university professors of paranormal, I accept, but why do they smoke? Here's Ray smoking, the iconic scene of the cigarette hanging off here. This wasn't scripted, it just happened and they kept it. Here's Venkman smoking for no reason, and even the radio host who's chatting about, he's smoking as well. And how many times have I seen Ghostbusters? 100 times probably. But it's a PG film for kids, aimed at kids. Jump forward to my first year at medical school, another film, Pulp Fiction. Here's Uma Thurman, and I hope you'll forgive me for saying that this is deliberately provocative. She's meant to be a sexy, alluring woman, lying down like this, but she's smoking because it adds to that allure. And that's the poster. That was the advertising, not just even in the movie, that's the poster. And in Germany, it's even worse. She's still smoking and she's got her gun, and then here they're smoking at the door as well. Vincent Vega, he's smoking whilst he's opening this. We don't know what's in here, gold or whatever it is. He's smoking. And when he takes Mia out to Jumping Jack Slims and all the dancing and thing, the first thing he does to break the ice is light her cigarette for her. So that's the 90s. Do you remember this scene in Basic Instinct? I've not clipped the scene itself, but is it not enough that she opens her legs to reveal that she's not wearing any underwear, but she's smoking as well? They made her smoke as well because it's sexy, it's alluring, and Philip Morris paid for that as well. But jump forward to 2019, and this is Stranger Things. Stranger Things is targeted at young people. It's on Netflix, and every single episode of Stranger Things Series 1, 2, and 3 has somebody smoking in it. It has the highest rate of smoking scenes of any TV show that's been broadcast in the last 5 years, and it's getting worse. It was double in Series 3 what it was in Series 2. And it's led Netflix to promise that they're going to reduce the amount of smoking in their TV shows. I accept that it's set in 1984 and smoking rates were higher, but it doesn't take the plot on anything anywhere to have Winona Ryder smoking at this point. Or this young man here. This is a very interesting review if you're interested in this sort of thing. While you were streaming, smoking on demand, a surge in the tobacco imagery putting youth at risk. They analysed to see how many shows on Netflix, and they just picked Netflix as the biggest versus broadcast or cable TV, and 92% of the shows on Netflix show some sort of smoking at some point. And that has clearly increased, it's trebled between 2016 and 2017, and it has continued to rise. So we are encouraging people to smoke in a sort of under the radar way, because people who smoke are either sexy or alluring, or they're powerful, or they're clever. They're our heroes. This just breaks down some of the programs. Stranger Things, you see, is a big one. The Unbreakable Kimmy Schmidt. It's a goofy comedy show, yet it has this enormous rise from one season to another. Orange is the New Black. We've banned smoking in prisons in the UK, yet in this program you can watch everyone smoking in prison. Daredevil, interestingly, which is Marvel, which is now owned by Disney, had no smoking whatsoever. Hopefully that will continue. And then broadcast television is not as bad, but even something like The Big Bang Theory still had 5 episodes that had people smoking in them. This is me at the top of the Col de Libier in 2012. Yes, I know this is Livestrong kit. I know there's the Armstrong stuff, but I wanted to believe. I believed in Lance Armstrong. I was wrong. This is facing north. We came up the south side. Beautiful day. Are people still smoking? Have I just whittled on for 5 minutes about all this advertising, but actually no one's smoking, because we all know it's bad for us. We've all seen the adverts. We've all seen people die of lung cancer, so we know that it's bad. And yes, the rates are coming down, and this doesn't go as far back as 2005-06 when the smoking ban came in, but I'll tell you there was a decent drop down. But this is all 4 countries in the UK, but you'll notice that although there's a decline, Scotland is the highest. apart from that year, but we're back to being the highest again in terms of the smoking rates. And it's still hovering around 1 in 5 people, maybe 1 in 6 people in the country smoke. And this is National Office of Statistics data. I've not just drawn these. This is looking at the demographics, and the group that continue to smoke the most are young people between 25 and 34. There has been a bit of a drop in the 18 to 24s, but this is still remains high. It is interesting that the older you get, the less likely you are to smoke. As you get into your 40s and 50s, you think, crikey, I'm living on borrowed time perhaps, and by the time you get into 65 and over, it's down to about 8%. My parents stopped smoking when they were in their early 50s, when they had grandchildren, and that was what seemed to spur them on to do it. But if you stop smoking at about the age of 50, it halves your risk of getting lung cancer, and your risk of ischemic heart disease goes almost back to baseline. But the point is that it's this group that we're advertising to, and this group is a worry. And of course, even by 65, still 1 in 10 people are still smoking and will die a smoker. How bad is it in Dundee? It is the worst in Scotland. This is a lovely little interactive tool. You can click on the different cities, just the whole of the country, the whole of the UK, and you can look at. I've clipped off some of it just to make it easier. But Dundee is the darkest colour. It has the highest smoking rates in Scotland at the moment, even higher than Glasgow. The lowest place in the country, East Dunbartonshire. 8%. Don't know why that is. West Dunbartonshire, 18. So there's a very fine line in Dunbartonshire as to whether you smoke or you don't. But you can see we are high in the whole region, but very high in Dundee. 21.8% of people smoke in Dundee, and it's 23.5% in the men. Cycling again, of course. I knew you were missing out on some cycling photos. This is the Mont Ventoux in Provence. This was a couple of years ago, and yes, it is that steep, honestly. The photographer lies on his side to make it look more steep, so we look as though we're working really hard, but it is pretty steep. And by this time, I'd seen sense and bought a compact chain set. That's probably a comment for just one person in the room, but there you go. So, how bad is smoking? Is it still really bad? Well, here's a couple of things. I said, what is the highest biggest modifiable risk factor in the Western world? And these are the first two things that come up. The first is that obesity is an important modifiable risk factor. I think we all agree with that. But they want to know, when will it overtake smoking as the biggest risk of cancer? And then this is from the American Cancer Society, that tobacco is still the most effective agent of death ever developed and deployed on a worldwide scale, which is hyperbole perhaps, but it makes good copy. How big is the problem in the UK? 8 million people smoke in the UK, roughly. About 5% of that group go to smoking cessation services. And most of smoking cessation processes are imperative on people wanting to stop. That is, they have to come to us. We don't go out to them in a very aggressive way. It's quite a passive thing. We say, hey, smoking cessation services are available. Why don't you access them? It's your problem, your lifestyle choice. You decide when you want to stop and come to us and we'll help you. Yet we screen aggressively for loads of diseases. Next week's Grand Round, aggressive screening for cervical cancer. We don't say, hey, it's your choice, you hang around and wait and we'll see what happens. As soon as you think you've got cervical cancer, come to us and we'll deal with it. Or breast cancer screening or whatever. It costs the NHS a fortune, 850 million a year in inpatient costs, 1.1 billion per year in primary care costs, and 696 million per year in outpatient secondary care services. So it's an expensive business. Yet, smoking cessation is the single most cost-effective life-saving intervention that we provide, according to the numbers. The cost of life per year, cost per life year gained in treating tobacco addiction is a 25th of the cost of a statin. We give out a lot of statins. One of the things I said at the beginning is that I'll try and persuade you that tobacco addiction is a disease. So, what is a disease? Well, it's an abnormal condition of the body part or an organ or a system resulting from various causes such as infection, genetic defect, or an environmental stress, such as breathing something in, that can be characterised by an identifiable group of signs or symptoms. And we in the NHS are here to provide equal and fair access to all patients for effective evidence-based treatments for that illness, disease, whether it be physical or mental. So, is tobacco addiction a disease, or is this just a lifestyle choice that people have made? Excellent. No one said, oh, it's gone. Don't worry, my ringtone is the theme to Knight Rider, so if someone rings me, it's much more embarrassing. So, what happens when you smoke? Okay, it's not really tobacco that people are addicted to, it's nicotine. Nicotine, and apologies for any neuroscientists in the room. Nicotine binds to receptors in the brain and releases dopamine. Dopamine is the happy hormone, makes you feel good, can make you feel calm, can make you excited, but dopamine's a good thing. When you don't smoke anymore, it stops, the dopamine levels fall, and you become irritable and stressed. You then crave more dopamine. The best way to get more dopamine is to get more nicotine, and that repeated exposure by smoking a lot leads to upregulation and hyperexcitability of receptors, and then you need more and more and more to get rid of those cravings, and then round and round and round and round you go. If you don't smoke, you get this concoction of different side effects of withdrawal. There's an environmental trigger of being short of nicotine, and you have a desire and a craving for it, and that could be treated with a drug. That drug is nicotine. And if you don't get treated for it, he says, moving around, if you don't get treated, you get withdrawal symptoms, and those withdrawal symptoms are very, very identifiable. So in terms of is this a disease, there is a recognizable environmental stress. There is a pathological condition, an abnormal change in structure and function of something in your brain, and there's an identifiable group of symptoms. So tobacco addiction, nicotine addiction, has been defined by some as a chronic and relapsing disease that often begins in childhood. So the nicotine part of it is pretty harmless all in all. It's very, very addictive, but it behaves pharmacologically very similarly to caffeine and releases dopamine, makes us feel good. There is a nice document that tells us that nicotine is pretty safe. It doesn't increase adverse reactions of any sort. Your cardiovascular events are okay. There's no cancer risk. You're not going to die if you just take nicotine by itself. And there are some adverse reactions, but they're not severe. It's all the other crap that's in cigarettes that causes the problem. Professor Jane Dacre, who was the president of the Royal College of Physicians, published this some years ago, or she read the introduction at least, wrote the introduction, hiding in plain sight. And we all know this, that we walk to the front door, the back door, the side door, a fire door, and people are smoking. And we don't challenge them, we don't ask them to move on, we don't ask them to stop, we don't offer them advice, we don't offer them help, they just carry on smoking and we just walk past them. And that's a lot of what they talk about, is that they're hiding in plain sight because they're just there, but we just walk past them. And Jane Dacre goes on to say that we must recognise that treating tobacco dependence effectively and routinely is our business, that we must treat this. She also says that failure to identify and treat smokers is no less negligent than failure to identify and treat patients with cancer. That's fairly strong language. Just to prove that I do cycle in Scotland sometimes, here's me in just at the top of Loch Earn on the South Road. It was a pretty wet and windy day, but I took my jacket off and when the sun came out just very, very briefly. So I do cycle in Scotland as well. How good are we then at doing what Jane Dacre says? How good are we at treating tobacco addiction? Well, this was an audit done in 2016, and they've not repeated it yet. This is the BTS, British Thoracic Society data. They looked at 15,000 nearly admissions from nearly 150 hospitals across the UK. Only 3/4 had their smoking status documented. Go to AMU and look at the clerking document. There's a very clear box that says, do you smoke or not, and how often is it filled in or not? Frequently it's not filled in. Why is it not filled in? Because we're very busy. Are we too busy to care? We, fill in the boxes. 28% were asked if they wanted to stop, so 50% of people who, they did smoke, but we didn't bother to even talk to them about their smoking. They're hiding in plain sight, we just let it be. 6% were referred to smoking cessation services if they existed, 4% were given NRT, and virtually none were given Champix, which is where the evidence base is, which I'll talk about in a minute. Only 1/3 had a smoking cessation practitioner, only 1/4 were able to prescribe pharmacotherapy for tobacco addiction at all, and 1/4 had consultant-led smoking cessation service, and over half didn't offer any training. So when we see smokers, we don't do enough. And secondary care is a target-rich environment. This is where the smokers are, okay? And this is an opportunity to be able to interact with them. 70% of hospital admissions at any one time are likely to be smokers, which seems a ludicrous amount, but smokers get sick. They are in the hospital. They are a third more likely to be admitted than someone who doesn't smoke. They are sick, they are in bed, they're not going anywhere, and you are doing a ward round, you're in front of them, you have an opportunity to spend some time with them, and that opportunity is, do you take your inhalers, do you take your medicines, do you do some exercise, do you want to lose weight, let's talk about your smoking. We don't do that because we think they're vulnerable people, and we think that they've got enough going on as it is. But it's important I'm going to talk a little bit later on about what happens to psychologically to a patient where you don't speak about their smoking cessation, you don't speak about their smoking. What does that patient think if you don't tell them to stop smoking? But we have this, where they're in a bed, they've got forced abstinence, they're going to have some withdrawal, but it's an opportunity to say, right, you've not smoked for 5 days in hospital, let's move on and not smoke ever again. We can mitigate the effects of withdrawal, and we can see what's happening there and then. We're right in front of them. We have long-term treatments which are effective, and I'm going to tell you about those in a second. So this is an opportunity for us to be able to interact with our patients and make a difference. And the Ottawa model of smoking cessation is why this is all kicked off. So this is Ottawa in Canada. They have an electronic system, so they can identify all the smokers that come through the door, and they systematically administered pharmacotherapy and behavioural support to all smokers in a hospital, secondary care environment. And they recommend this, which is the 5 A's of ask if you smoke, advise that we can do something about it, assess what their risks are, help them into their smoking cessation, and arrange follow-up, not the 5 D's from Dodgeball. Does it work? This is the. If you remember just one slide, then remember this. This is what's that? 3 years, 2 and a bit years follow-up from giving either normal smoking cessation, which is just whatever happened, maybe you'd mention it, maybe you wouldn't, to intervention of aggressive smoking cessation at the point of admission. The arrows have moved a little bit, I'm sorry, but mortality was halved at a year. Halved. What medications and interactions and things can you think of at the top of your head where you can halve mortality with an interaction at the point of admission or point of discharge? That mortality reduction at 2 years was still there, and quit rates were significantly better, 50% better at 6 months. That's not enough to sell it to the bean counters, though. What they wanted to know was, well, does it save me a bed day? It's all right that you're saving lives, but you're keeping people out of hospital, and this is the data about readmission, that you can halve readmission rates at 30 days, so within a month you've halved your admissions, and at a year it's down from 40-ish down to about 25, and these are impressive enough p-values that even Tom is happy with that. We can treat people's nicotine addiction by giving nicotine replacement therapy, and you can give them patches, and that's what we do here, and there's various strengths. You can give them gum, they can have inhalers, lozenges, sprays, etc., and it reduces the cravings by binding to nicotine receptors. It releases dopamine, happy hormone, people feel good, and you can desensitize those receptors by giving slower release nicotine, which is what the nicotine patches are. They give slow release. They don't give the hit that smoking gives you. One of my colleagues, who's now gone to Australia, tells me that when he was trying to stop smoking as a teenager, he had nicotine patches and he used to scratch them. And if you scratch them, the release goes up, so you get a spike. I don't recommend that you go out and tell all your patients that, but there's ways around all sorts of these things. The problem, of course, is that you end up swapping one addiction for another, and you go from nicotine patches, from smoking to nicotine patches, and then once you get out of the hospital, you just go back to smoking again, because you're still getting, but basically it's still dopamine addiction that's happening. But nicotine replacement therapy is pretty effective. It increases your chance of stopping smoking by about 60% compared to doing nothing at all. And if you add behavioural support into that, then that helps even more. And it's cost effective in terms of quit rates, and this is about what it costs. The QALY cost is only £634, and you know that the threshold for that is 30 grand. So NRT is good. It works. But it doesn't work as well as this, which is varenicline, and this is the only version of this drug, so I'm not picking one company's version of a drug versus anybody else's. They're the only people who make it. And it works in the brain by cutting off the link between nicotine going in and dopamine being released. So they say that it alleviates the symptoms and cravings of withdrawal, and it reduces the reward. And this is the big bit, because when you smoke, your nicotine gets released, the Champix stops the release of dopamine, so you don't get that high. You don't feel good anymore, and because you don't feel good, you don't want it again. And so people say is when they're smoking on Champix, they just get to the point where they don't want to smoke anymore, they pick a quit date, they carry on taking the Champix. If they do smoke, they fall off the wagon, then it just doesn't taste very nice, they don't get the high, and that helps them stop smoking. Evidence, buckets of evidence. 2007 NICE guideline here. They looked at 2 big trials, pretty big numbers in this, looking at varenicline, Zyban, and placebo, and clearly it's a lot better than placebo. Odds ratios of 4-ish in this study. So varenicline works much better than placebo, but then so does NRT. But these odds ratios are much bigger, not that you can compare 2 studies directly to each other without a decent meta-analysis. And the meta-analysis here suggested that varenicline was better than NRT and better than Zyban as well. So NICE concluded that varenicline is superior to NRT and superior to Zyban, and it's cheaper and it's more cost-effective in all sensitivity analyses and should be the first-line treatment. It should be given with counselling and support, but if you don't have counselling and support, you should still give it anyway. This is NHS England chat, that when NICE recommends something, you should provide it, and that's the rules. I'll take you back to the 2016 audit from the BTS. This had been around for 9 years, and in that audit, virtually nobody gave varenicline to anybody. It was like 0.01% or something like that. So we're just ignoring very strong evidence base and recommendations from NICE. If you want to know the kind of estimates of the abstinence rates, if you just give brief advice and say smoking's bad, stop it, that's your risk of the abstinence rate at a year is about 1%. Mono NRT, combo NRT, Zyban, varenicline. Mono NRT plus support. Support helps everything, but the best thing is varenicline plus support, up to 25% here, and in some later studies it's nearer 40%. So, move forward the clock a little bit to 2012. 146 randomized controlled trials have been done in this area to look at what is the best form of smoking cessation, and varenicline is the only treatment that demonstrates effects over the other options. So it is the best way to get people to stop smoking. And if you're into this sort of thing, number needed to treat, then to get a lifetime quitter versus placebo, NRT is 23, Zyban 22, and varenicline 11. So I have to admit that up until about a year or 18 months ago, I didn't know about this. I had no idea. I was trying in the ward to say, you should really stop. People say, I don't fancy stopping. I say, do you want to stop or not? No, I don't. Okay, we'll leave you alone then. If you don't, you'll never stop unless you want to stop, so I'll just leave you be. And I'll hold my hands up, and I did that. I've been doing that for a decade as a consultant. But it's not right, because there's no evidence whatsoever to show that you need initial motivation to be able to stop. In studies that look at motivated quitters and non-motivated quitters, there's no difference between the quit rates. You don't have to be committed to be motivated to do it. There is no motivational ladder of, I'm thinking about it harder, I'm now at the point I want to quit. That's not how it works. You either go out for a run or you don't. You don't build up to it. That's in my brain at least. Maybe you do build up to it. Alpdewez, this is a while ago, 2012. Look, I'll give my look. I look just the same as what you're saying. But yes, this is 2012 up in the Haute Alps, the 21 village, the 21 corners of Alpdewez. And this was on that stupid standard chain set. I don't know what I was thinking. Is it safe? Yes, it is safe. And it's safe in all sorts of environments. These are trials are looking at people who've got cardiovascular disease, people who've been admitted with acute coronary syndrome. So you come in, you have your acute coronary syndrome, you get your PCI. Can you have varenicline on discharge? Yes, you can. It's safe. What if you've had depression before? Yes, it's safe to give it to people who've got stably treated current or past major depression. The big one is this study here, which is the EAGLE study. Because people think if you give varenicline to people, they're going to have a massive depressive illness, or they're going to try and kill themselves. And because there was a black triangle on this drug for some time. The EAGLE study was the largest trial of smoking cessation therapy ever done, and it was asked for by the FDA. The FDA said, right, yon company, and other company that make the three things, you have got to come together, work together, and do a big trial to compare the safety of all these drugs. It was a huge study. It was double-blind, triple-dummy, placebo-controlled, randomized. It doesn't get much more complicated than that. So they were either on actual Champix, dummy, placebo Zyban and placebo NRT, and round it went. Okay, and they got 12 weeks of treatment plus further treatment in a 24-week trial, and they got 10 minutes of smoking cessation advice at each of 15 visits. This is the line you want to look at. That in terms of the primary endpoint was a composite of did you have a neuropsychiatric illness or problem at the time. During the process. These are people who had never had a psychiatric illness before. These are people who had a neuropsychiatric disorder before. And if you've never had a neuropsychiatric disorder before, the biggest there is about a 1.3% risk of having a neuropsychiatric problem whilst you're stopping smoking on varenicline. It's 2.2 on Zyban, it's 2.5 on patches, and it's 2.4 if you have nothing at all and go with placebo. So there is a 1 to 2% chance that something is going to go awry with your neuropsyche when you stop smoking, because you're screwing around with your dopamine. So something's going to happen in about 2% of people. But it's no different depending what drug you're on. The only successful suicide, successful is not the right word, completed suicide, I take this very seriously, was in the placebo arm, okay? And the suicidal ideation was actually had 0 in the Champix varenicline arm. Now, if you had a previous psychiatric problem, then those rates go up. They go up from about 2% to about 6%. But there is no difference across the arm. Perhaps a slightly less in the placebo arm, but between nicotine and bupropion and varenicline, it's just the same. So that's the bottom line on here: is that yes, there is risk in stopping smoking, but it doesn't matter what treatment you're on. There is actually more risk if you carry on smoking, and everybody who, once they do stop smoking, their hospital anxiety depression score gets better. There you go. So their average HAD score improves from baseline through the treatment phase by 2 points and 3 points in the psychiatric. So it's good to get off the fags. So the outcome of this was that you shouldn't worry about giving varenicline to people who've had previous psychiatric problems. You just need to warn them that there is a chance it might happen again. And you tell them if you're having problems and you're feeling depressed and anxious, you're having suicidal thoughts, then seek help. But that's the advice to everybody. So this should not stop us giving people. It shouldn't stop us giving people Champix. And if you want to know, did it work? The primary outcome was the safety data, but they obviously measured quit rates, and the quit rates in the non-psychiatric cohort, psychiatric cohort, and overall are much better in each one of these groups for the people on varenicline. Okay, they're pretty good in the other groups, but they're significantly better in all groups on varenicline. So in the past, I put it to you, and this is from my experience of what I have been doing for the last 10, 15 years, of telling people, hey, smoking's bad, you're making a bad lifestyle decision, and you need to change your behaviour because you decide to smoke every time that you light up or you buy a packet of fags, that it's bad for you in all ways, nicotine's terrible, it's your choice, if you don't get through it, it's your fault, you've not tried hard enough, it's all about willpower and you really need to stop. What is suggested now is that we think of it as, it is a disease, it's a chemical dependence. The treatments do work. There's an evidence base for them, and we all should be every time we see a smoker, we should be doing something about it. In the same way that we measure their blood pressure, and if it's high, I refer them to Jake. If you don't mention smoking in clinic or an admission, then it's been shown in some qualitative studies that patients walk away and think, well, if they didn't mention it, it can't be that important. So I'm all right. Or even worse, they walk away thinking, well, every other doctor has told me I should stop smoking, but that doctor didn't mention it. I must be doomed. I must be beyond the pale. It's not worth stopping now because I'm doomed. Mont Ventoux from the Saute approach, beautiful climb this. This car got in the way. But it's a beautiful climb. That roasting hot day last April. It's fantastic. So what have we done about it? This is East Block, where the respiratory clinic is, not my bike. There is definitely a need because we have high smoking rates, and we know that we have treatment that works. So we sat down when Blair and the Smoking Cessation team came to see us to say, why aren't we doing more about this? Say, well, yeah, why aren't we doing more about this? We should do more about this. We have a target-rich environment. So it said, well, let's do something about this. Let's take the respiratory outpatient patients. Let's make some sort of process so that we can detect who the smokers are, and let's do the hard sell. Let's sit in clinic and say, right, you're smoking. The single most important thing you can do to improve your respiratory outcome and your overall outcome is to stop smoking. I don't want to talk about it. Okay, but here's a treatment that we know can work. Your chances of stopping smoking can go up to 30-40%, and I can give you the medication right now. So that was the big difference, is we gave them the medicine right there. Here is a box of Champix. That will last you. Get started. Take it right now. Let's get cracking. And then go to your pharmacy to engage in follow-up with the pharmacist, and the pharmacist will carry on giving you the Champix. And we got buy-in from the pharmacist to do this because they're very keen to do this. And we standardized the process, and we just thought, let's just get on with it. So the patient comes in, healthcare assistant takes a carbon monoxide reading. It's a simple little thing you blow into the machine. If it's less than 4, then you're probably not a smoker, and you just carry on. If it's more than 4, you probably are a smoker, or you've got a very bad gas fire at home. And we never had any of that, I don't think, did we? We were worried there might be some of that, but there wasn't. They were all smokers. And then we gave them a questionnaire and said, right, the consultant will talk to you about your smoking. And they come through to me or whoever, and they may not want to engage in the process, but I could go quite a hard sell. And I say, well, it really is important. Oh, I don't want to talk about it. Well, let me tell you about it. Or they say, yeah, let's go on with it. Tell me all about it. So even if they say they really don't want to know, we give them a leaflet and say, well, think about it. But basically, most people, in my clinic at least, we told them, varenicline is the way to go, first-line treatment, evidence-based, let's go for it. They're consented for it. We sign a piece of paper. We give them the varenicline. They go to their pharmacy of choice. We note it in track care. And then either the patient goes to pharmacy or they don't, and we can't really affect that. But this is much higher a chance if we've given them it right there and then. Okay, and then we follow them up. Public health phone them up at 1 to 2 weeks. Are you still doing it? How's it going? And have you quit or not? And we've followed all this up to look at our quit rates, and Blair has more information about that. And the key we found was actually giving them the gift, giving them something to their hands right there and there, not just, you know what, you should go to the pharmacy and see about it, and they go, yeah, and then they just go down the Tesco and then go home again. Just get them the drug in their hand right there and then. And it worked very well. We've got a decent uptake. The telephone support's been fantastic. The team have phoned up and give more support and more support and more support, and you find that people, not only the patient has decided to stop smoking, but their relatives and the people they live with, they've all decided to stop smoking as well, and it sort of snowballs. And actually there's lots and lots of support because most people who smoke really do actually want to stop. But it wasn't quite the target-rich environment we thought it was going to be. There wasn't quite as many smokers in clinic as we thought there would be, which is interesting. We have a video on a little tablet, which we had in clinic, and only one person said they'd seen it. But then also we have Homes Under the Hammer on telly, so they were watching that instead. A few patients we couldn't contact, but we're going to try and catch up with them. And there were a few people who, once we'd given them the advice and gone through it with them, they still were a bit uncertain about what to do and how to do it, so we refer them on to pharmacy. And what we're going to do, we're going to carry it on, and the very brief advice is a very important part of that process, but we're going to try and get as many people as possible through the clinic to stop smoking, because it's a teachable moment and a point when we do have a bit of time to sit with a patient and explain to them that this really is the most important modifiable point. Here's my favourite cycling photo of all time, which is me and my son. And this is last year before, and this is child 1 having gone up his first category 1 climb. So that's a very proud moment for me on my old bike. And this is the Col de Bellon, the pass of the Pretty Man. I just leave that hanging. So where is this target-rich environment, which I thought was going to be respiratory outpatients? It's on the wards. I've said this already. The people who smoke, who get admitted, they're on the wards. They're on the wards, they're in a bed, they can't go anywhere, they feel a bit rotten right enough, or they're getting better, or they're improving from an operation. They're on the wards. So that's what we want to target next. We want to get out onto the wards and start doing this to people who are for their discharge. And where do we go? Well, vascular surgery is the obvious first choice. My window from my office looks out on the East Block, and Ward 12 is pretty close, and they come down two floors on the lift, round a bit, down another floor on the lift, and they wheel themselves out to outside my window, and they smoke outside my window. And so I know how much this is going on, and no legs, both legs amputated above the knee, and they continue to smoke. These are the people we need to target, because it's never too late to stop smoking. They're often quite young. Rheumatology. Any rheumatologists here? They're very keen on getting engaged in this process because smoking really, really affects your rheumatoid arthritis, and that's a very common disease. So they're very keen. I met an orthopaedic surgeon as I was walking here. What are you doing at Grand Rounds? I told him, he said, that's great, we've got loads of smokers in orthopaedic surgery, and actually it'd be really great, they all get osteoporosis. Let's engage, send me your talk. It's on YouTube. So almost everywhere, dermatology, Andy, there, in the breast clinic, where else? Hypertension clinic, you name it, there's going to be smokers, and we can find them. So we need to get out there onto the AMU. They might only be in the ward for 24 hours, but that's 24 hours where you can make a difference and give them their Champix. So here's this is not official, this is not out there yet, this is just in my head what we do. Identify smokers at the point of access to care. Very brief advice immediately. Everybody, as soon as, whether it's a nurse, FY1, a consultant, a reg, whoever it is, says, oh, do you smoke? Yes. Can I offer you some very brief advice about that? Yes, I can, on a go. Very brief advice about what you should do and what's available. And then treat their nicotine withdrawal straight away. You're going to withdraw from your nicotine whilst you're here. Let me give you a nicotine patch. And then we can talk later about nicotine dependence, tobacco addiction, and offer them varenicline as first-line therapy for smoking cessation. We then dispense it with their discharge script or at the clinic, and then they have community pharmacy follow-up. So if they accept it, you give it. If they don't, you send them to pharmacy anyway. And this is what we've started to do in Ward 3. It's now gone through all the committees it needs to do, and we're doing this on Ward 3 now. I've done it twice this morning on our ward round of people who are heavy smokers. You think they're never going to quit in a million years, but we sit down and say, here's the drug, take that, go, let's see how you get on. If you don't shoot, you don't score. That's one of the things I learned a long time ago. And, better to shoot 10 times and score once than it is to just sit waiting for the perfect opportunity. Jens Voigt, cycling hero of mine, said that only 1 in 10 breakaways results in a victory, so I need to go on 10 breakaways. The people who do this well are Manchester. Withenshaw Hospital in Manchester, a guy called Matt Everson, I've met him, and he gave me some of these slides for today, so I must acknowledge that. But he leads the lung cancer service in Manchester, and he's rolled out this thing called the Cure Project, where this is basically what they've done. The Ottawa thing, what I've just described, they do it very aggressively. Anyone who comes in, very brief advice, somebody swoops in, varenicline, go, go, go. And this is what they've achieved in a very, very short space of time, 6 months. 96% of patients are provided with very brief advice. 51% get NRT by the admitting team. 61% have a specialist assessment. 10% get varenicline. We're way better than they are. 824 people in the Cure team have provided, they've done 824 medication prescriptions, and the quit rate has gone up 42% in 6 months. That's astonishing. Now, they've had money put in to do it, but it's astonishing that the change they've made. Compare what they've done to the 2016 audit, where 6% of people are giving smoking cessation, and in the 6 months they've got they have 61%. 4% get NRT, 51. None get varenicline, 10. The Cure Project at .co.uk, interesting website. They've got loads of videos and things describing basically what I've just said. Really, really interesting stuff. They also have in here a cost calculator. You put in what your non-maternity, non-paediatric admissions are. They then work out what if your smoking rate in the hospital is about, let's say call it 20%. Then it tells you how many smokers are admitted in a year, most likely. What does that say? I can't read it. Reduction in readmission numbers per annum and the cost savings from reduction in readmissions. This is English data, so it's commissioning. It's not directly applicable to what we do. But if the hospital our size in England would save £2.2 million in a year by following this model. So if you're not convinced by the health benefits, then be convinced by the money saving. What could you do with your slice of that £2.2 million? Buy a new bike, obviously. So that is me done. I'd like to thank a number of people particularly Matt Everson and the Cure Project, because I mean that they have really been the trailblazers in this and driven it on. And Matt very kindly has given me some of the slides from his presentation to give to you today. The outpatient team, particularly Karen, who's our healthcare assistant, without whom it wouldn't happen. She unfortunately was not very well for a brief period of time, and just her going meant that the numbers just dropped off. It's very interesting that it was so dependent on her doing the CEO monitoring. But it just shows it's everyone's responsibility to do this. Arlene Shaw and the rest of the pharmacy team who've been pivotal in driving through getting this onto formulary. Andrew Radley in public health has been very helpful to me in putting this together. And Blair and his team are the real heroes here because they do all the work. They've done all the stuff to drive this forwards. And of course, I'd like to thank my parents for making this dream a reality. I leave you with the last photo at the top of the Calder Glandon, and I thank you very much for your attention. I'm very happy to take questions. Tom McDonald, sir.
The problem I've found is that patients do an internet search on Champix, full of suicidal ideation, psychiatric problems, still out there provision, and as frank as they are.
Yeah.
Now, shouldn't the BTS lobby to get these things removed from the internet? Because you can actually get this disinformation removed if you ask for it, which is factually incorrect. But it still prevents out there. Patients are read this, they go, I'm not taking this drug, it makes you kill yourself.
Yeah, I think so. I'm not running around with microphones. I'm sorry, but the question for the YouTube is that there's a lot of information out there on websites of people anecdotally saying I took Champix once and I wanted to kill myself, and people access that information. You're absolutely right. I think it is beholden on the BTS to go and lobby to get those things down, and I know that Matt has talked to the BTS about that. BTS Council is in 3 weeks' time, and I'm going, so it's something we're going to talk about. This is an ongoing problem with social media and access to data for everything, isn't it? That you don't see the good news stories, you just see the bad stuff, and we are trying to direct people towards the good news stories. But I think you're absolutely right, because if you Google, does Champix make me suicidal, you'll get 1,000 things come up before you get anything that says no, it doesn't. And
There are companies that specialise in removing this stuff, that you can just contact and do it for you.
I will speak to the BTS, honestly, at council. I'm going to the BTS. Andy?
Yeah, I mean, that's a fair point, but it's not unique to Champix. I'm a dermatologist and prescribe called Nicotine. And it's very similar to the history of suicide ideation. So we produce a document on our patient information leaflet that contradicts all the stuff online. Because I think it's probably not realistic to get all that stuff online. I mean, it's all there for years. But if you had a nice leaflet that said you will read stuff online, the evidence is this. And overall, we suggest we take it out.
So Blair is nodding that a patient information leaflet to contradict the fake news out there would be a good idea. Are you going to say we've got one, or we're going to do one? We've got one. There you go. He's already one step ahead of me. He has been one step ahead of me for the last 6 months in all this. So you're right. Providing robust information that we can get out to people to try to contradict all that terrible fake news is important. Anybody else? Ben, at the back. So the question is, do we give it to people whilst they're inpatient, or do it on discharge? We're doing it on discharge for the reason you describe of it works best when people are still smoking. And the plan is that they start the Champix while still smoking, they set a stop date, and then they stop whilst tilting the Champix, continue the Champix on, and then if they do smoke, then it generally feels horrible. So we're not giving it to people whilst they're an inpatient, we're giving them NRT to get rid of the cravings whilst they're an inpatient, and that might need a lot of it. And then at the point of discharge, we're saying, right, you're going home now. You can have the patches if you want, but the best thing now is to have this Champix. Here's the box with your TTO of your steroids and your antibiotics and your beta blocker. On you go. So that's a good point. Isla? You had your hand up, sorry.
One thing my children always comment on if they're ever here is that they see more people smoking outside the hospital than anywhere else they ever go.
Yeah.
Can you update us on what's being done to discourage that image of smokers?
Yeah, the next thing I was going to talk about if I had time, but I realised I didn't have time, is about smoke-free environment and that whole push to make the hospital a smoke-free environment. It's very challenging because although the rules are no smoking on the premises at all, you can vape on the premises, but you're not inside the hospital. Who is out there policing that, and what's the enforcement that we have? And when the smoking ban came in 2005-06, whenever it was, everyone worried that there'd be no enforcement, but people would just carry on smoking inside pubs and things anyway, because who's going to enforce it? But it was auto-enforced. The public did that, and guys in people in pubs, they said, out you go, and it became the norm to move outside. Our problem here is that how many of us have walked past smokers at the front door and not challenged them on it? We don't challenge them because we're a bit scared of doing so. We feel what they're going to say back to us, and it's the beginning of the day, we've got a long day at work, and the last thing we need is the aggravation of having a full-on argument with someone. I go outside my window 2 or 3 times a day to move people on and tell them to stop smoking. And I often say, if you want to come inside and talk about smoking cessation, I'll do it. But that's a huge amount of effort, and I'm an enthusiast, let's say. What's happening about that, I don't know. Blair might be able to tell me what the clean air process is, but I agree with you. It is a concentration of people smoking at the door. It looks terrible.
So, in public health, it's asked bringing a new policy this year. So the new legislation coming in later this year from Scotland government.
It's so important.
Sorry. Yeah. Okay. Hi. Hope everyone can hear me. So later this year, legislation will come in place, so it will be illegal to smoke on hospital grounds within 15 metres of a hospital building. So you will be, anyone caught smoking could be partial to fines up to £1,000. So obviously that's pending on, Brexit's just passed, so it's been put back and back and back again. So what we're doing as a team at the moment is obviously working with wards. Respiratory, we're leading the way in terms of supporting patients inside. We're spreading this work now on the pathways in the formulary. You'll see that we've changed the language, so there's tobacco addiction pathway and prescribing guidance. That information's available. The training's there with it as well. We can come out and support that within the wards. Obviously, outside's a big issue. We've worked with paediatric wards, working with patients, children, to develop voices to go out into the current tannoy system. I know it doesn't fix the issue. The blue button, I don't know if anyone's seen that on level 7. We're rolling that out to other areas and other hospitals in Tayside as well. There's a lot of ongoing work that's needed with this, but I'll pass you over to my colleague Margaret, who might be able to update a little bit further from a national point of view.
Certainly, sort of from the best practices around, all the hospitals are having the same problems and things. Locally here, as you see, we've actually closed the Fresh Air Garden, and actually that's reduced the amount of smokers at the front door. It doesn't do it totally away, but the amount of smokers that we used to have there was absolutely, we couldn't condone it. We had to do something about it. Working on from that, we are in consultation with the policy and how we work with patients, but it is very much about everybody's responsibility. We need everybody to be doing at least a VBA. Every opportunity that you've got a patient who's a smoker, it's about asking them as a smoker and having that continued conversation. So it's not about saying you need to stop, it's about where are you on the scale, and how are you going to move, what can we do to support to move you along that scale so that you are at a point where we can actually support you to do something about it in a very supportive way.
So I'll draw things to a close because it is after 2 o'clock and people need to get on, but what I have here is a canvas bag full of the information about what we're talking about. This is what some of here is. It's got Champix information in it. It's got very brief advice trainings if you don't know what to do about that. It's got our prescribing guide for NRT. It's got the pathway in it. It has the patient referral form for Champix in the community. It even has the Eagles study. If you want to read it in more detail, we've got a summary of that. And I have about, I'm being bleeped, I have about 20 of them. So if you want to take one away to talk with your department, please come and grab one. Thanks very much for me for talking, and thanks very much for you for coming. And next week, it is HPV-associated cervical cancer. Thanks very much.